Welcome to the Myeloma Matters podcast, hosted by the Multiple Myeloma Research Foundation, focusing on patients' experiences with and perspectives on multiple myeloma topics that matter to anyone affected by this blood cancer. In this episode, you'll hear myeloma patients providing first-hand accounts on the importance of continuing treatment after induction therapy and autologous stem cell transplant, and about what to expect with this type of ongoing treatment. Please note that every myeloma patient is unique. The information in this podcast is not intended to replace the services or advice of trained healthcare professionals. Please consult with your healthcare team or contact the MMRF Patient Navigation Center at 1-888-841-6673 if you have specific questions about your health. If you'd like to support this podcast series, we'd love for you to leave a comment or review wherever you get your podcasts. Most patients begin treatment for multiple myeloma with a course of induction therapy, which aims to reduce the number of myeloma cells in the body. This is followed by consolidation therapy, which involves either more medication or an autologous stem cell transplant if the patient is eligible. But treatment doesn't stop there. Myeloma patients require additional long-term treatment, known as maintenance therapy, because there is a high likelihood that the myeloma will come back, which can occur for a number of reasons, such as myeloma cells remaining in the body after induction and consolidation therapies. The goal of maintenance therapy is to prevent or delay myeloma from returning. Our three guests today, Elizabeth Bohannon, Linda Lane, and Catherine Mohorn, are all currently receiving maintenance therapy after their initial induction and consolidation therapies. They all received induction therapy with a 3 or 4 drug regimen. Both Catherine and Elizabeth received induction therapy, followed by a stem cell transplant, but Linda chose to wait for her transplant. She's hoping that the steady advances in myeloma treatments will soon reach a point where transplants are obsolete. For all three of our guests, maintenance therapy is especially important because there are features of their myeloma that make it more aggressive or more likely to relapse. Maintenance therapy offers several benefits. It helps delay disease progression for longer periods and reduces the risk for early relapse. Studies have shown that it also helps prolong survival. As Linda's doctor explained to her, an aggressive approach to maintenance therapy was best for her given her high-risk disease.
So because of being light chain, because of the translocation, because of how I had that spike very quickly, he wants my maintenance plan. He said, I'm going to treat this with a heavy hand. He said, we can always pull back, but he said, my tendency with you is going to be over-medicate and then pull back as we see fit.
With this additional therapy, all of our guests today have maintained their responses for at least 1 to 2 years, despite their high-risk disease. This prolonged window of disease control gives Elizabeth hope. She knows her disease is likely to return, but she's optimistic about the myeloma treatment options that will be available when that happens.
The feeling I have right now, my current mantra might make some people squeamish, but I say to myself when I have a bad day, not dead yet. And what that triggers for me isn't, oh my God, I'm going to die, because we all are. But it's like, I'm here today. So how do I want to choose to live this day? And that's really important to me. And I'm able to do that because I have such knowledge about all the research that's going on and all the drugs that are being developed and what's happening with CAR T therapy, where it's advancing every month. And so I feel better that by the time I'm ready for CAR T, that it will be ready for me, that it'll be a better, even better treatment than it is today.
Maintenance therapy not only extends responses, it also deepens responses. This extra treatment helps by reducing the number of myeloma cells left in the body and slowing the recurrence of new myeloma cells. Many people who receive maintenance therapy achieve a much deeper response than they would have without it. The deepest response a patient can have is called minimal residual disease, or MRD, negativity. This was the case for Catherine, who was initially treated with an induction regimen of Kyprolis, Revlimid, and dexamethasone, commonly known as KRD, before her stem cell transplant in September 2021.
I responded well to the KRD, and when I had the stem cell transplant, I was still responding. I mean, you don't take anything for a while after that. You're off of all the medications. But when they started looking at things again, they were seeing like a light band in the blood that made them think that there was still a little something there.
Catherine's doctors put her back on the KRD regimen for her maintenance therapy, and she was found to be MRD negative in October of last year. For most patients with standard risk myeloma, as opposed to the high-risk myeloma our guests had to contend with, the standard maintenance therapy is Revlimid, given at a dose of 10 or 15 milligrams per day for 21 days, usually beginning 100 days after a transplant for patients who receive one, or right after completing induction therapy for patients who don't receive a transplant. This gives the patient's blood cells a chance to recover and repopulate. Patients with myeloma that has genetic or clinical features indicating that it is more aggressive are said to have high-risk disease, which means that they are less likely to achieve long periods of remission. These patients are more likely to relapse quickly after their initial treatment than patients without high-risk disease. There is no standard treatment approach for high-risk myeloma, but most myeloma experts prefer to pursue an intensive treatment plan, as Linda's doctor did. This typically involves using a combination maintenance therapy regimen consisting of Revlimid and at least one other agent. This regimen is sometimes started sooner after transplant, such as after 60 days rather than after 100 days. All of our guests are receiving a combination maintenance therapy regimen. Elizabeth and Catherine are both receiving KRD, whereas Linda is receiving Velcade, Revlimid, dexamethasone, and Darzalex. According to the multiple myeloma treatment guidelines, maintenance therapy should continue until the myeloma progresses or until the patient develops unacceptable side effects or asks to stop treatment. Revlimid is a pill that can be taken at home. Patients on combination regimens, however, often need to make regular visits to a clinic, as some parts of their treatment need to be given as infusions or injections. As Catherine explained, it can be difficult making a maintenance therapy schedule fit into your busy life.
I would say that we've had to just juggle our lives around it, which can be a real pain, trying to make travel plans. But, you make it work. You just do what you have to do.
Fortunately, her care team is willing to work with her to make sure she still gets the treatment she needs.
Because of traveling and stuff, I've gotten off track a little bit. Like I had to take a month off when we went to the East Coast for a month. But they feel good enough about the way I've responded that they don't. They told me I need to live my life, and if I want to take a trip, we'll just skip a treatment. But they want to get the 24 cycles in, even if it takes a little longer.
Though Linda understands why her frequent clinic visits are so important for controlling her disease, it can be difficult to cope with emotionally.
And I will say, it wouldn't have changed my decision, but I did not expect to have to go in every other week. I really, as I was sitting in the treatment room each time, you spend a lot of time there, and every once in a while, someone would be able to ring the bell and, that they were done with treatment, and you'd be so excited for them. And, they make the big deal, the doctors and the nurses, and they didn't have family members there because it was COVID. But I just would sit there and be like, oh, I'm so excited. I can, I'm looking forward to ringing the bell. And then it was like, I'm never going to ring that bell. I'm never going to be done. I'm a very faith-centered person, and I can weather a lot, but that really did bother me for some time because it was very heavy. It was like, I'm never going to be done, and I'm going every other week. That precipitates another trip to the lab, so I just felt so tethered. And then, that little voice in my head says, the longer you're going every other week, the longer it means those meds are working, that you're still in that response. And that turned things for me, for the positive, like, okay, all right, this is what it is.
Elizabeth agrees that living with myeloma, both the disease and the treatment, can be overwhelming. But she says that introspection and self-care can go a long way in helping build resilience through all the treatments and tests, and she hopes they can help other patients cope with these realities.
So it's part of the dance of this disease I've found. I don't know how this will land with other people, but for me, it's about making friends with myeloma because it's never going to leave me. Maybe someday there'll be a cure. But until then, just like every myeloma patient, even when you're in remission, it's not gone, and everyone knows that. So you have to find a way to live with it. And so my view of living with it is to support my body as much as I can, do mindfulness work, learn how to breathe properly, and to self-soothe, to calm myself, because when I get scared, that's when things can come unraveled so easily.
Doctors encourage patients to stay on maintenance therapy for a minimum of 2 years. Studies are ongoing to determine whether Revlimid can be safely stopped without compromising potential benefits, especially in patients with deep and sustained responses. If a patient is having trouble tolerating maintenance therapy, their doctor may first try to adjust the dose to eliminate or minimize side effects before considering stopping treatment. Catherine has discussed dose adjustment with her doctors, who are considering reducing the amount of medication she is having to manage her side effects.
I mean, I'll be honest, it makes me nervous to be completely, done with the Kyprolis. I just worry that it's going to make it come back faster. But at the same time, I'm kind of ready to get this poison out of my body, I feel like I'm taking poison every 2 weeks. I'll just listen to them as usual, and if whatever they recommend, that's what I'll do.
The most common side effects of Revlimid are fatigue, rash, or gastrointestinal problems such as constipation or diarrhea. Revlimid can also cause low blood counts, which may increase the likelihood of developing certain infections. Linda deals with frequent fatigue and occasional GI issues as a result of her Revlimid treatment, which have forced her to make adjustments to her daily routine.
I live like a toddler. I take a nap in the morning or in the afternoons, and I go to bed at 8:30 at night. That's not so bad when you look at, what other people deal with. But so it was a little bit of a tougher transition than I had anticipated. And a lot of it was just kind of like, okay, all right, let's just get in the groove again.
Because of her side effects, Linda also recently had to make the difficult decision to stay home from an overseas trip with her husband and sons.
My husband has always wanted to go to Ireland. That's one place we didn't get to yet. And I was like, take the boys. And they planned this wonderful trip to Dublin and Edinburgh. And they were really sad that I wasn't going. And I was like, I would be back at the hotel and you would be worried about me, and plus too, with the occasional GI issue, I just, I'm not, So I went vicariously. They sent me plenty of pictures,
Elizabeth experienced a short episode of changes in her blood counts, which fortunately resolved quickly on their own. However, as she explains, the constant unknown of what to expect can be challenging.
They did a CBC, and all of my blood counts had plummeted. I don't know, even my platelets were like 128. Everything had plummeted, and I was saying, what is going on? And then a few days later, I got some sort of stomach bug and was flat for a week. And when you have myeloma, that it's one of those things you have to get used to. When you get a cold, you think, oh my God, I'm going to die, or oh my God, my disease is roaring back, or you don't feel like you're in the world with everyone else anymore. And so I probably just had a little norovirus or some stomach bug. But to me, it was a scary week because I didn't know what was wrong. And that combined with my counts dropping. But then I went in for chemo on Friday and all my counts had rebounded. I don't understand it, and I don't think my doctors do. And that's just the way it is sometimes. You just have to get used to not understanding everything that goes on in your body.
Maintenance therapy is given indefinitely, and some patients may find that its side effects become intolerable over time. Again, if you experience problematic side effects while taking Revlimid, your doctor may want to first try lowering the dose of Revlimid before considering stopping treatment altogether. This was the case with Catherine, who developed a rash while taking Revlimid. Adjusting her dose after talking with her doctor helped her tolerate these effects.
If I was out in the heat, that's when it would kind of affect me. Underneath my clothes, I would get like a rash and kind of itchy and everything. And so they reduced me. Now I'm on 5 milligrams, and I'm not really seeing a rash on my body, but like we play golf a lot and I wear a cap, to keep the sun off of me. And like around the band, like where the hat fits, I get a little rash in my hair, like my scalp. If that's what I have to deal with, that's not the end of the world. It's a lot better than having a rash all over my whole body.
Medications that can help you manage treatment-related side effects are usually available, such as Imodium to help with diarrhea. Other medications can help target the underlying causes of the side effects. Changes in diet may also be helpful to address or avoid some of the potential side effects. In rare cases, Revlimid and other immunomodulatory drugs have been linked to the development of new cancers, also known as second primary malignancies. In studies where this was observed, Revlimid was used with melphalan, the main chemotherapy used during autologous stem cell transplants. The secondary cancers seen in these studies included blood cancers such as myelodysplastic syndromes and acute leukemia. Skin cancer is also of concern. However, with appropriate monitoring, this type of cancer can be caught early and managed. There have been very few second primary malignancies seen in studies of Revlimid where melphalan was not part of the treatment. The information available to date indicates that therapy with Revlimid significantly decreases the risk of myeloma progression, and most doctors believe that the benefits of Revlimid outweigh the risk of secondary cancers. As always, it's important to discuss any concerns you have about treatment with your doctor. If a patient does need to discontinue Revlimid, their doctor may switch them to a different type of drug, such as a proteasome inhibitor like Kyprolis, Ninlaro, or a monoclonal antibody like Darzalex. If the patient is already on 2 drugs, the other agent may be continued and the Revlimid discontinued. Ultimately, it is important for patients to receive and stay on maintenance therapy as long as possible, as studies have shown that patients are at greater risk of relapse if maintenance therapy is discontinued. If you are having any issues with your treatment, no matter how insignificant they might feel, it is important to talk with your care team and discuss your options. To learn more about what to expect with long-term myeloma treatment, let's hear more from Linda, Catherine, and Elizabeth, who joined the MMRF's Mary Derome to discuss their experiences with maintenance therapy and share the challenges they've faced, the adjustments they've made, and what their extended responses have meant to them.
Thank you so much for being with us today on our podcast on maintenance therapy. Each of my guests today has gone through the traditional steps of initial treatment for your myeloma, which includes induction therapy with a triplet regimen, with or without a stem cell transplant. And now you are all on some form of maintenance therapy. The current standard of care for maintenance is single agent Revlimid. So Elizabeth and Catherine, you are both on a triplet maintenance regimen, and Linda, you're on a quadruplet regimen. So this says something to me about the sort of your subtype of disease, which I'm imagining must be, at least in the case of Elizabeth and Catherine, is probably somewhere in the high risk spectrum. Whereas Linda, you're on a quadruplet, and it's because you have not yet had a transplant, right?
Correct. And I'm also in the high risk category as well.
So let's talk a little bit about how you came to be on 3 or 4 drugs instead of 1. And Linda, let's start with you.
Well, I was diagnosed in May of 21 as a result of long COVID. That's how they found it. And the doctor with whom my local doctor was going to do the standard Revlimid, Velcade, dexamethasone, and then go on to stem cell transplant. And we also brought in a specialist at Dana-Farber, and I had been doing some research as well, and I had been finding some things about daratumumab, and I had asked him about it, and he said, yes, absolutely, we can add that on if you'd like. So he did do that, and he said, hey, we'll see how you do. Maybe you'll get to the point where we can decide, does it make sense to do the stem cell transplant, soon after, or if it's something that you can defer. We opted to defer, but the agreement was as long as I had the stem cells collected. So we did pause treatment for the few weeks that it takes, that you have to do ahead of time, in order to collect the stem cells. And during that time, my kappa spiked. So I quickly went right back down as soon as I got back on treatment. My doctor at Dana-Farber just felt that, okay, for maintenance, let's keep a very heavy hand based on, one, my profile, with it being light chain and with translocation, but also because of how I reacted during that short period of time where I was off. So I think that's how it's come to be that I've continued with the 4 drugs.
So Catherine, what about your story?
I think it was November of 2020. I was just in for my regular routine physical, and my doctor's always really, good about all the blood work. And my proteins came back elevated. I think they were at 9.5, and I think the range was like 6.5 or 6 to 8.5, something like that. And he said, well, you look like the picture of health, but if you were my wife, I would just want to check it a little further. So they did, the urine test, and they saw the Benz-Jones proteins. So initially, I was actually diagnosed with smoldering myeloma, and we were living in North Carolina at the time, and we moved to Park City, Utah. And within 4 months, I went from 18% plasma cell to 80%. So I became active in 4 months. So I immediately started the induction therapy. They found an extra leg on chromosome 1, which isn't like a textbook high risk, but they think that it has the potential to be one of the high risk categories. And so they put me on Kyprolis, Revlimid, and the Dex. And they chose Kyprolis because they feel like that one's better for that particular abnormality, and also because I'm a super active person and I would be less likely to have any kind of neuropathy from that than like the Velcade. And then in September of 2021, I had a stem cell transplant. I continued going in for the same triplet therapy. I guess you have the break right after the stem cell transplant for 90 days or whatever it was. And then they put me back on the same regimen. And I am still currently on that. I get chemo every 2 weeks, IV, and then I take Revlimid. And they are only making me take the Dex when I have the treatment, just hopefully to avoid some side effects. But anyway, that's the plan. And after I was MRD negative, it took about a year for me to be MRD negative. So if it continues, by the end of this year, they're hoping to have me just on the Revlimid. And I'm hoping that too, because it would make my life a lot easier. I'm sick of having to make my travel plans around that.
Elizabeth, how about your story? How did you end up on, and you're taking the same maintenance as Catherine is, right? So you're taking KRD.
Yes, I am. I was diagnosed in February of 2021. Interestingly, it was a brand new chiropractor who saw the classic lytic lesions of multiple myeloma on a set of head and neck x-rays that he did before initiating chiropractic care. I'd been having a lot of rib pain for over a year. I thought it was intercostal muscles. I'm also, like Catherine, very active. I am an equestrian, so I was riding and I kept blaming myself, saying, well, you're clearly not doing enough core workouts, so therefore you're pulling your intercostal muscles. That was the story I had, but it had gotten very debilitating. It was hard for me to sit. It was hard for me to move. It was hard for me to sleep. So I thought, well, I'll go to a chiropractor and see if I could get an adjustment. And that's where he saw the lesions. And that began my journey. I'm being treated at UCSF here in the San Francisco Bay Area. I also have intermediate to high-risk disease. I have a 1q deletion, 1114 translocation, and extensive lytic lesions in every bone in my body. I also have the problem of having non-secretory disease. So it's not PET scan avid. So the PET scans don't pick anything up. The blood work doesn't, nothing in the urine. If you didn't look at my bone marrow biopsies, you wouldn't know I have this disease, which makes it really challenging when it comes to treatment and monitoring me. So the first round of induction therapy, my doctor wanted to put me on carfilzomib, but my insurance company refused. So I had to go on traditional Velcade, Revlimid, and Dex, and we elected to do a 6-month induction instead of 4 months because the only way we would be able to measure my body's response was by bone marrow biopsies. And my doctor didn't want to expose me to more of those than absolutely necessary. So we did 6 months of that. Then my bone marrow biopsy showed that while we had gotten some response, I started out with 40 to 45% plasma cells, and we brought it down to maybe 20% or 25%, but it wasn't enough for me to be transplant eligible at that time. So we switched to another regimen, and then I went on daratumumab because I'm also CD38 positive, and daratumumab targets the CD38 protein. I had high hopes that, daratumumab plus 2 other drugs. It was a triplet, including high dose of Dex. It was weekly daratumumab injections. And that went on until December of 2021. And then we did another biopsy, and my plasma cells had actually increased while on daratumumab. So I said I'm done for a while, and I took a break. I took 6 weeks off and went to Mexico to celebrate my 60th birthday, my husband's 70th birthday on the beach with the whales, and just not think about it. And then I came back and we decided to use big guns, and I was admitted for high-dose Cytoxan. So I did high-dose Cytoxan and high-dose Dex. And after that, my counts came down to transplant eligible, even though I will say at the time I thought there's no way I can go through a transplant after this. But I rallied and I did. So I went into the hospital in May of 2022 and started maintenance therapy with carfilzomib and Revlimid and a very tiny dose of Dex. I hate it, just like everyone. So we're down to 8 milligrams of Dex only on carfilzomib days. And that's because we tried to do carfilzomib without anything, but I get these terrible shaking chills from the carfilzomib. So we do it with as small a dose of Dex as I can handle to manage the side effects. And I've been on that maintenance therapy ever since. I've never achieved MRD negativity, but on biopsy, my counts have stayed kind of at a low roar for that whole time.
Wow. So your insurance wouldn't approve Kyprolis for your induction therapy, but they approved it for your maintenance therapy.
they insisted that I was like everyone else and needed to go on the standard of care for my initial induction. And I tried everything. I wrote letters. I had friends at Blue Shield try to, advocate, but didn't work.
So you also said that you have a T1114, right? Did you have venetoclax at all?
It was Dara and venetoclax, and Dex was my second induction regimen.
Yeah, that's quite an interesting induction.
It was miserable because my doctor said to me, Elizabeth, I just feel like every time we meet, it's with bad news. And I said, yeah, I feel that way too.
So you've been on this maintenance now for a period of time, or you've had MRD testing, and you're not MRD negative to this point. So you're still ongoing with the therapy. Catherine, you said that you're ongoing with your maintenance therapy, but you have reached MRD negativity. So your response to the therapy has deepened, and you said it took you about a year to get to the point where you went from being MRD positive to being MRD negative, correct?
They kept seeing like a slight band in the blood work, and they just wanted that to go away, and it took a year for that to go away.
So Linda, do you have any data, or have you heard anything from your doctors about whether or not your response to the therapy that you've been on so far is actually deepening on your maintenance, or if it's kind of staying the same?
Well, they have not retested me for MRD negativity, so I've only had 2 biopsies, one at diagnosis and then the other in October of 21 in preparation for the collection. So my doctor felt as if, you know what, the only reason why we're doing another bone marrow biopsy is just to see MRD negativity. We want to continue with the plan anyway, so we can hold off on that. And I was fine with that, quite honestly.
So let's talk a little bit about side effects of all of these drugs that you guys are on. And these are like some pretty serious drug cocktails to take on a long-term basis, right? So normally people are taking only one drug. They're taking Revlimid and then with dexamethasone for maintenance, but you guys are on these very, serious and strong maintenance therapies. So let's talk a little bit about how those are impacting like your day-to-day life. Elizabeth, how are you dealing with your therapies as time goes on?
In all honesty, I've changed my life because of multiple myeloma, and it served me well. So I eat a plant-based diet now. I'm religious about my sleep. I work out with weights. I hike. I ride my horse. I do yoga. So I'm super active, and I think that served me well in terms of side effects. I have a tiny bit of neuropathy, but it only really shows up when I'm in bed at night and I feel it like a burning sensation on my feet. But that's about it. So I've been pretty well. I will say, though, I took another holiday from drugs in order to go hike in Alaska to raise money for the Multiple Myeloma Research Foundation. But I trained for 3 months for that, and then I went on this trip, and it was about 6 weeks off from all the drugs. And then I came back and had to get my last set of 5 vaccines, because you have to get revaccinated after transplant. So I had my last set of vaccines plus Xgeva for bone hardening, plus carfilzomib. And that hit me like a rock, I have to say. And I cried a bit. I really missed that feeling of living in a well body. And I didn't realize how much I was putting up with in terms of fatigue and energy, reduction in energy until I was off the drugs for a while. So I think I have more fatigue than I would otherwise, but you can get used to it. Already, since I've been on now, 2 cycles, I'm okay.
And how often do you find yourself going into the clinic?
Every other week.
And does that impact your schedule as well?
I go on Fridays, and I try to go on Friday afternoons, and what gets me through, because I really don't like being a patient. I don't like being so connected at the hip to a hospital and an institution like that. So mentally, I just think of it as another appointment. So I go in and usually carve out Fridays and consider them me days. I try to do fun things on Fridays as well as chemo, and that helps.
Catherine, how are you doing with your maintenance therapy?
Well, like Elizabeth, I mean, I just try really, really hard to be positive and just to keep on going. I just don't let anything stop me. I was on 40 milligrams of Dex, and I've been trying to wean off of it. I'd gotten down to where I was just taking like 3 pills versus 10. And the last 2 times I've gone, I've gotten fairly sick afterwards. Just like I got the chills, really shaking chills and high fever. So I'm going to have to bump it back up, I think, at least to the 5 and see how that goes. But I am tired, more tired than I used to be, because I never even knew I was sick. I mean, it was completely picked up on a routine physical. The only thing that was going on with me was that I was a little bit dizzy at times, and they told me that that could have been, the myeloma cells crowding out the healthy cells. I'm doing okay. I'm just trying to stay positive, and I go every 2 weeks as well, but we plan trips around that, and that kind of keeps me feeling happy. Get ready to go to Alaska on a cruise next week, so looking forward to that. But yeah, overall, I'm doing okay.
Okay, that's good to hear. Linda, how was your experience? Now you're on 4 drugs still, and are you getting the DARA as an infusion, or are you getting it subcutaneously?
It's sub-Q. It was always sub-Q. Like Catherine and Elizabeth, fatigue is my biggest issue. I go back to bed every day. Like, I'm fine in the morning. I feel like I, have to budget my activity. What do I want to get accomplished in the morning? And then when I get up from my nap, it depends upon how I feel, what I accomplish for the rest of the day. And, logistically, it's an issue. Psychologically, it takes a lot to go from being very active and doing things and doing for others, and not being able to do that is very hard. But in the mornings, I always try to check the box for, my physical health, my mental health, my spiritual health. If I can do that each day, then I consider that successful. But it is tough. And I also, like the others, I'm in every other week, which then precipitates a trip to the lab for blood work every other week. So it's just, in induction therapy, you really were in the battle rhythm. And that kind of extends into maintenance, that routine. And it's okay, because it can shape your week and your activities. But other times it feels like, man, this is really getting in the way. This is frustrating.
So when you were talking to your care team before you were making all these decisions about whether or not you're going to have a stem cell transplant, and if you weren't, then how that was going to work out, did your care team, really talk to you about the drugs you were going to be on and what you might expect for side effects before you went on them?
We knew, we had the laundry list of what to expect. I mean, they tell you fatigue, they tell you nausea, they tell you vomiting, they tell you constipation, diarrhea. I do deal with GI issues, although, I've been able to manage that. But sometimes it's like, okay, I need to make sure that I'm close to a bathroom, and sometimes you just kind of hang at home if you're not feeling too confident. Sometimes you don't wander too far off the reservation on those days. But yes, they give you the laundry list of side effects, and it's just kind of, all right, well, see what hits you. And sometimes others hit you, and some other cycles, maybe it's not so bad.
So, Catherine, was it like that for you? Did your care team prepare you for what you could expect as far as side effects when you started your maintenance?
They did. And every time you go in and you get, well, at least for the Revlimid, you get that packet that tells you everything that can happen. And for the most part, it is the fatigue. I have also had bathroom issues, like walking my dog. And it's like, okay, I'm going to have to stop and run home now, because and when it comes on, it just comes on like that. And I forgot to say that I haven't had severe neuropathy, but I've been having cramping in my hands, like almost like a Charlie horse. And I started taking potassium and magnesium, and that seems to have helped a little bit with that. But yeah, they did. I mean, they've been very, very helpful, and I just kind of feel like they're family. I know all their names, and there's so many of them. They've been great.
Elizabeth, did your care team prepare you for what you were facing with your maintenance therapies?
I think so. Although, quite honestly, I don't really remember those conversations. I think I remember what I want to remember. And most of the time, I want to believe everything's going to be just fine. That's my sort of my mindset. And then plus side of that is I don't spend a lot of time being anxious. The downside of that is when these side effects show up, I'm like, wait, what is that? And I'm a little shocked. So I, like the others, have also had all kinds of GI issues, but I mean, primarily diarrhea. And it is okay as long as I'm home, as the others said. But when I was training for Alaska, it was scary because the thought of having to hike these long hikes in Alaska and have diarrhea was terrifying. So but it's interesting. It comes and goes. It's not all the time. When I went back on drugs after taking that holiday from them, my scalp was itching, like crazy itching. And my doctor said, oh, I think that's Revlimid. Start taking Claritin. And don't you know that the itching improved? Yes. So some itching and GI issues and fatigue. And I will say, of all of the drugs, aside from the high-dose chemotherapy drugs, which are in another class by themselves, but of all the drugs I've taken, the Dex is far and away the worst.
I did want to ask you, Elizabeth, like so you've gone on a couple of drug holidays since you've been diagnosed. So I wanted to ask you, what did your care team think about these drug holidays? And did you have to sort of really, I mean, do they just say, when you tell them what you want, they just say, oh, okay? Or do they try to sort of talk you out of it? Or do they try to let you know some things you can do to help yourself while you're on the drug holiday? How does that work?
I've been really lucky in that regard. My care team, Dr. Wong, who she just left the practice, but she's been my doctor up until just now. And she always said, your life is the most important thing to me. Your choices are the most important thing to me. As long as you're informed, you get to choose. And so I always see it as I've got the keys to my car and I drive. And when I need a break, I need a break. I couldn't have hiked in Alaska on those drugs. So I knew I needed a break. And when nothing was getting me to transplant ready, I needed a psychological break to celebrate my birthday. So I just did it because I needed it. And I can see doing it again. I mean, it will depend on what happens with this most recent biopsy, but I could see doing it regularly for my mental health and my physical health.
People have different ways that they really sort of approach that, what they need for themselves.
There was a woman on my hike who was diagnosed when she was 30 years old, and she's now 48. And she did 2 transplants and never achieved remission even, much less MRD negativity. And she decided to take the keys to her car after that, and she's been off all drugs ever since. And her way of referring to it is, my myeloma and I coexist quite nicely. And she monitors her counts, so she will know when they start to rise, but they haven't. And I mean, God, that's awfully lucky. But that was her choice. And I found that very empowering for me personally to hear her story.
Yeah, and I was pretty amazed because this is not something that you hear routinely from patients, right? So, and I think it's something that patients do actually need to hear on on a broadcast such as this, that is an option. If you decide that that's a way that you want to go, it is an option for patients, and care teams will respect that because, I mean, it's the keys to your car, like you mentioned. Catherine, let's talk a little bit about your caregiver and how if you have a caregiver, like how the caregiver can help while you're on maintenance and can help with the side effects that you're having while you're on maintenance.
Well, I see my doctor, Dr. McClune. I see him about every 3 months. And then there's a PA named Mary that I see really whenever I need to. She pops by probably every 2 months or so. But I'm primarily just, I go in and have my blood work done. Then I go into the infusion room and there's probably, I don't even know how, probably 20 nurses in there. And they always ask me, has anything changed since last time, any more side effects? And, I haven't had to do anything special for the side effects. Well, they did reduce the Revlimid. I'm down to 5 milligrams. I was on 25 milligrams. And that was primarily because I was getting really bad rashes. Fortunately, not on my face, but like anywhere that I would sweat, like, my stomach, and I've had an itchy head too. I just started using medicated shampoo, and that kind of helps some, but it's still kind of itchy. If I have any questions, they answer them. I'm kind of a rule follower. I just listen to what they say and trust that they have my best interests at heart. They say the same thing to me about traveling, that you need to live your life. That's more important than anything else. And so I have taken a couple of breaks for like a month. We drove cross country, and I was going to fly back for treatment, and Dr. McClune said, absolutely not. You just go have fun. Everything's looking good. We'll just check when you get back. And so far, so good.
So Linda, are you married? Is your caregiver your husband? Is he helpful to you when you're having your side effects and your maintenance and all that stuff?
My husband, and then at the time I was diagnosed, my boys were in college, and they were kind of in and out. And honestly, they could not have been sweeter. It was really wonderful. And people were trying to get a meal train going, for that. And one of my boys loves to cook, and he just took over. And it was really honestly, I feel like I did something right, So that was wonderful. But like the others, I do see either my doctor or the nurse practitioner a little bit more regularly than they do. I see either one in the beginning of each cycle as just a check-in, and this is where I have my treatment done locally, and then I go into Dana-Farber in Boston. Probably down to every 5 months at this point. But all of my blood work goes, and they're always monitoring it too. So I feel lucky to have an extra set of eyes.
And Elizabeth, how about you? You have so you're also married, and your husband, I think, is he plays a pretty big role to help you through what's going on.
Yeah, I mean, I'm also just background-wise, it might help explain my attitude toward the keys to my car. I started off my adult life as an oncology nurse. And so back in the 80s, when inpatient oncology patients pretty much all died. So that, cancer was a different beast back then. Myeloma for sure. I mean, you pretty much had a year. So I have some of that. My husband is also a retired transplant physician. So together we have a lot of, it's not even so much knowledge, because that background doesn't really help you when it's your body and your disease, but the attitude of exploration and pushing the boundaries, it might just be how I was born, but I also think that my background informs some of that. But my husband has been my thought partner. So when we have to make decisions, we talk it through together. And I also have children. I have 2 daughters. One is 31 and one is 29. And they've just been incredible, just powerful resources for us, almost, as much, if not more, than my husband. We've been married for 33 years, and you have habits, whereas your daughters, at least my daughters, have just really stepped up. And then I have a pretty extensive friend group. Of course, when you get sick like this, you quickly learn who are the ones that you can really depend on to be there for you when you really need them. Yeah, so I get support when I need it, and when I don't, I literally mentally try to pretend that I don't have this.
When you asked me, I was the first, so I thought you were talking about my caregivers at the hospital, but my husband has been so awesome. And this is such a God wink, but he actually retired in, I think it was July of 2020, before I, of course, was diagnosed. And he is a retired endodontist, and he has come with me to every single appointment and has just been so great. And I just can't thank him enough. But yeah, he's been great. And my kids, I have 3 kids. They've all been very supportive too. And she's so right, Elizabeth is so right about friends. You really know who your friends are.
So you guys, I mean, everybody's on at least 3 drugs, and some of you are on 4. Linda, have you ever had a discussion with your care team of whether or not they might want to drop 1 drug or 2 drugs, or just change your maintenance based on what's happening with you?
The last time I was in at Dana-Farber, which was May, Dr. Nadim suggested that, all right, we'll revisit whether or not we pull back on the dose of something or eliminate something altogether. I'll see him next in October. The end of January will be 2 years on maintenance, so he was saying most likely then. I don't know what will happen. My kappa number, which is my primary marker, is trending upwards a little bit, still in the normal range. So my guess is he won't do anything like that in October and perhaps revisit in January. But he does, each time he kind of says, all right, here we are, maybe we'll tweak things. So I started my maintenance on 15 milligrams of Revlimid. In induction, I was at 25, and they brought me down to 10 just to try to help with the fatigue. He has tweaked things up until this point. So he'll say, all right, this is what we're going to do. And then down the road, maybe this is what we'll try to let you know what the next step might be.
Catherine, have your doctors talked to you at all about maybe tweaking the your maintenance therapy and changing it, or maybe removing one of the drugs or anything like that?
At the end of November, I think it will have been 2 years since the transplant. And they said that they're going to hopefully take me off the carfilzomib infusions, maybe entirely. I may have to just do it once a month, but I'm sure I'll still be taking Revlimid. I don't know what dosage, and I don't know about that Dex. We'll see.
Elizabeth, have you ever talked to your care team about whether or not they're going to tweak your therapies at all?
Funny you should mention that. My new doctor is Dr. Wolf at UCSF. I chose him after Dr. Wong left because he's gone on record saying he believes that there's a cure for myeloma within the next 5 years, and he's not going to retire until there is one. But yeah, I'm always thinking about that because as much as I don't know how the others would feel, I'd love to live a long life, but I'd far rather live a good life. So I'm very attached to the idea of being able to do what I want to do. And so I'm always thinking about what's possible. And so I think about CAR T, but I also recognize that when you're able to live your life and it's pretty good, I'm not eager to change things up, because while we are getting more and more drugs approved and more options, I don't want to run out of options. And so I'm a little more calm about that than I was in the beginning, when I was really hell-bent on achieving MRD negativity and, I had this idea of a long-lasting remission, and I'm aware now that that may never be the case for me. And so it's about that balance. What gives me the best quality of life for the longest period of time is really my goal.
So thinking about if and when your myeloma decides to reassert itself and rear its ugly head and your labs start to go up, do you think about what therapy you might go on next? Or, if you are having this resurgence of your multiple myeloma and you get your opinion from your doctor as far as what they think your next therapy should be, would you consider getting a second opinion from another doctor? Linda, how would that work?
Well, I kind of do already have 2 doctors, but yes, I mean, if I needed a tiebreaker, maybe I would. We do have a very dear friend who is an oncologist, so I would run things by her. Knowledge is power. I think I would just keep seeking until I was comfortable with whatever decision we made. To Elizabeth's point, I liked her analogy of, we have the keys to our car. I mean, if I were to relapse soon, the thought was, okay, if you relapse within a certain amount of time, you'd go to stem cell transplant. Well, you know what? I've been reading a lot about all these other great things. So if there are newer technologies, bispecific and CAR T, hey, I might try to push for something like that.
I believe that you're correct, and it's probably a good thing to think about having a second opinion and just knowing all the options that are available to you and then making that decision from there. Catherine, how would you go about that type of decision?
I think that I would want to get another opinion. I'm very lucky that I actually have a myeloma doctor that lives in my neighborhood, and she said I can always come to her with questions. She works for the other hospital, there's Intermountain Healthcare at the University of Utah, but she said that doesn't matter. Anytime you have a question, feel free to ask me. But I feel encouraged that there is so much going on with the research. And see, Todd from the Multiple Myeloma Research Foundation, he comes to see me like once a year when he's in Utah, and he was here, I don't know, a month ago or so, and he said that it's a possibility that they'll be able to just use blood work instead of having to have a bone marrow biopsy in the future. I love that. That would be great. But yeah, I would want to get another opinion if it was a significant change. I don't think that I want to be part of like a trial just because of being high risk. It wasn't even an option for me this time around. I hope these medications that they're coming up with are going to be the key to our future, and I sure hope that there is a cure in the next 5 years. That'd be awesome.
There's a lot of work going on in the high risk space right now, because that's really a huge area of unmet need in multiple myeloma. I mean, there's, approximately 25% of myeloma patients are in the high risk category, which is not a small number of people. And they're just, depending on what types of chromosomal abnormalities people have, the standard of care therapies may work, but they may not, right? So the whole field is really moving more towards risk-adapted therapies. There needs to be more work in that area, which at the MMRF, we are starting up a number of grant programs to look at that, and also a number of trials to look at that as well, this risk-adapted therapy, and determining, based on people's chromosomal abnormalities, which therapies might be the best for them because they are high risk and they have these abnormalities. So it's a very, very active area of research. And as we know, the myeloma doctors are all brilliant. So I can imagine that they'll come up with a solution for this in time, right? So it just takes some excellent research, which is always ongoing. And we hear about it every year at multiple meetings about the great results people are getting in these studies. So Elizabeth, so how are you thinking about what's going to happen with you, if and when you get to the point of relapse and you need to go on some other therapy?
I have done a second opinion once, and I would be interested in hearing other people's experiences with second opinions, but I did it before I went on Cytoxan. And I did my second opinion through the Mayo Clinic program. I found it unsatisfactory, to be honest, because even though I consider myself someone who stays on top of the research and is pretty educated about my disease, when it's patient talking to doctor, so much gets lost in translation. So I came back to my doctor with the Mayo doctor's opinion, and my doctor said, well, did you ask him this? Did you tell him that? What about this? And I'm like, no, I didn't ask any of those questions, and I didn't tell him that because I'm the patient. In my view, that I would love to get a second opinion, but properly. And I think for me, a second opinion could be valuable if doctor's talking to doctor, or at least institution to institution. I'm not able to communicate about my disease at the same level as my provider could. So I would totally want to do it, but not as it's set up now. They take thousands of dollars for something that doesn't get you very far.
So Catherine has already said that she's not interested in a clinical study because she's a high-risk person. So if Dr. Wolf suggested to you to go on to a clinical study, would you consider that?
Oh, in a heartbeat. When I was a nurse, I ran clinical trials. So I have experience with them. I'm also very much chomping at the bit to get into a clinical trial down at the Hoag Research Center looking at alternative to bone marrow biopsy. So immuno PET scans is the thing I'm looking at, but I can't get into the trial until I officially relapse, and that's a whole definitional thing. But yeah, I would for sure do a clinical trial, maybe not a phase 1, for the reasons that Catherine mentioned. That, if you're looking at an option that might buy you more time or better quality of life, I wouldn't want to be in the in a phase 1 trial. But I don't think that's really what most of us are talking about anyway. It's really about earlier access to some of these novel drugs, and that has a lot of appeal to me.
Yeah. So there are some interesting things in phase 3 right now, these immunomodulatory drugs that are analogs of Revlimid and Pomalyst. So iberdomide and mezigdomide are in phase 3 trials. So they might be the next ones that are going to be approved. So Linda, would you consider going on a clinical study if your doctor thought it might be your best choice?
I would consider anything. Whether or not I do it, I think it depends. It depends upon, where I am, what it is, how badly I'm feeling at the time, what my history has been, So I will definitely keep my options open.
So, and you still haven't had a transplant, right? So that's still like a big option for you, right?
It is a big option, although it's an option I'm hoping not to have to do.
I guess what I'd like to do is close by asking each of you, if you were talking to a patient who was sort of in the same boat as you were in, right? And maybe they have been diagnosed and they've had a transplant and now they're on maintenance therapy. What words would you say to them as words of encouragement or how to sort of get through? And I think we've had somewhat of this discussion already in the podcast, but Catherine, let's just start with you. What would you say about your experience and how you approach things and how you would advise another patient to approach things?
Number 1, be positive, eat right. I think exercise is key. It keeps me feeling better physically and mentally. And don't give up. You can live with this. And, I kind of compare it to having AIDS, that you can live for a long time. You just have to take the medication, but you can live a very fulfilling life.
So I think it's very interesting that, as we go through the years and have been going to these big medical meetings every year, last year people started talking about in these meetings a cure for myeloma, which is something that I had not heard before, right? So we certainly have progressed to the point where it's become almost a chronic disease, right? So many people can stay alive for quite a long time as long as they keep on top of things and they're on maintenance therapy and their labs are watched. So if they start to have a recurrence, they can go on something different. And newer drugs are coming onto the market all the time for myeloma patients that are in their later stages. And these later stage drugs are becoming more and more effective. Back in the old days, you couldn't expect more than a 20 or 30% response from these drugs for patients who had seen, 4 or 5 lines of therapy, but things are getting much, much better these days. So, Linda, what would your advice to other patients be?
Well, I think I would start with, life certainly is very different than we imagined, but it can still be great. Similar to what Catherine said, I think activity is so incredibly important. I work with a trainer twice a week, weight-based training, which is so good for the bones. I'm out walking year-round, depending upon, if it's the weather, sometimes I don't get out. But yes, I think physical activity is so important. That old commercial, a body in motion stays in motion, is so important. And in my prior session, my father-in-law passed away from multiple myeloma, so we were very familiar with what it was. And when he lost his mobility, it was the beginning of the end. Granted, he passed in 2002 when there was so very little that could be offered to him, but I really do think that his lack of mobility really accelerated things.
And Elizabeth, I'll let you have the last word.
I would say a few things. One is that while staying positive has been really important to me. There's also, it's a hard journey. It's not easy. It's lonely. People look at you and they say, you look great. And then they think you are great. And it's not great. So I think it's okay for it not to be great and for you to get the kind of help and support you deserve because it's not great. So get a therapist, join a support group, talk to your loved ones, whatever it takes to get the support you need, do that. Because no matter how great you look, it's not great. It's hard. So I think I would definitely say that. I would also echo the others about there are things that are within our control. Certain things, we can't control what our plasma cells, what our myeloma cells are doing, but we can control our diet, our sleep, our exercise, so take care of your body as best you can. I think that's been a really key to my experience. And also stay informed. The more that you know, the better you can advocate for yourself. And so I think for me personally, it's really important to stay on top of the research, to attend MMRF webinars, to learn as much as possible, because it makes me a more informed consumer and I can ask those tough questions.
Thank you, ladies, for all of your pearls of wisdom that you have imparted during our podcast. And I'd like to thank my panelists today, Elizabeth, Catherine, and Linda, for answering all these questions and just being such great partners in this discussion.
Thank you for listening to this episode of the Myeloma Matters podcast on myeloma maintenance therapy, hosted by the Multiple Myeloma Research Foundation. The MMRF thanks Elizabeth Bohannon, Catherine Mohorn, and Linda Lane for sharing what it's like to live with myeloma and be on some form of treatment indefinitely. The MMRF also thanks AbbVie, Amgen, BMS, Cure, Genentech, GSK, Janssen, Karyopharm, Sanofi, and Takeda Oncology for their generous support of this podcast. If you have additional questions about what you heard today, call the MMRF Patient Navigation Center at 1-888-841-6673. If you've enjoyed this series, be sure to leave a comment or review wherever you get your podcasts.